There we go. All right, so what we're going to be talking about here is we're going to be focusing on HCC, which is liver cancer, primary liver cancer, as kind of a model for talking about liver-directed treatments that we do in interventional radiology. A lot of what you're going to see and some of the data I'm going to show is applicable to other disease states as well. So we're kind of taking the approach of, starting with the procedure, branching out, and then coming back again a little bit to be a little bit more focused. But HCC is just a good example that gives us a framework to kind of think about and talk about these topics. So we're going to go over a little bit of how we diagnose and stage these things, and then jump more into the specific treatments. And we're going to spend most of our time talking about the arterial therapies, but also talking about ablation as well. So HCC is different than many other cancers throughout the body in a lot of different ways, and I'll get to the two most important ones for our purposes right here when we get started. So one is in terms of diagnosis. HCC is almost, not exclusively, but primarily to a large degree found in people who have underlying liver disease. And this is either hepatitis or cirrhosis of some sort. It can be from alcohol, it can be from viruses, it can be from metabolic disorders. But what makes it unique is that when a patient has cirrhosis or underlying liver disease that causes this underlying injury to the liver, and they develop something in the liver, it is very commonly going to be an HCC, right? So it's not that patients who have cirrhosis can't get colon cancer or lung cancer or other things that might go to the liver, but when they get a tumor in the liver, it's most commonly going to be HCC. But what's interesting about it as well is that that tumor is going to behave very specifically. And this is going to be important for us for a couple of reasons, and I'll just mention it the first time now, but you'll hear it over and over again, is that the blood flow to these tumors is typically supplied by the hepatic artery. And what that means is it's going to create some opportunities for our treatments, but it's also going to make them look a specific way on imaging. And that plays out in terms of it looking unique in such a way that we can actually diagnose these tumors based on imaging alone. So what this chart here is saying is that if we have certain imaging characteristics up here on the right, if they meet those characteristics, we can diagnose HCC about 95% of the time on imaging alone. The fewer those characteristics it has, the less likely it'll be HCC. So we can have things that we can look at a scan, a CT or an MRI, and say that is almost a 0% chance of it being HCC. Or we can go up and we can say that has a 95% chance of being HCC. So what are those characteristics? So again, the tumor is supplied by the artery, which means that if we do a scan during what we call the arterial phase, so that means you inject the dye into the patient's vein, it goes from their veins to their heart, from their heart to their lungs, and then it gets pumped out back to the heart and then back out to the arteries. So after the pulmonary artery lights up, the next thing we're going to see light up is the aorta. So this is called the arterial phase. You can see the aorta is right here and it's extremely bright. The liver is not so bright yet, but the arteries, these little dots here, whether they're in the liver over here or outside the liver over here, are all really bright. So because the tumor is supplied by the artery, during this phase, just like the arteries are bright, you're going to see parts of the tumor get very, very bright. Then, as we wait about 90 seconds, now we're in what's called the portal venous phase. So now the blood has gone into the arteries, out into the organs, out to all parts of the body, and is starting to come back through the liver, again, this time through the portal vein, the other main blood supply to the liver. We'll see a diagram of this in a second, but as it starts to go through again, this is about 90 seconds after this first picture is taken, we're now in something called the portal venous phase. So if you look here, these dots here, the ones that the arrows are on, these are branches of the portal vein. Now you can see during the arterial phase, you didn't see them at all because the blood hadn't reached them yet. But now during the venous phase, you can see that now these are filling up. But what's interesting that happens during the venous phase is because the blood rushes into the cancer so quickly through the artery, by the time you get to the venous phase, this area starts to look relatively dark compared to the background liver. right? So this area right here was very bright, and now it's darker compared to the background liver. As the liver gets brighter, the tumor gets darker. This phenomenon of seeing it bright here and darker here is what we're looking for when we see HCC. So that characteristic puts it in what we call the LR5 or LIRADS 5 category. We don't have to go into that, but from the last slide, this is that 95 to 98% probability of HCC. Now that is about as good, actually, that is better than most biopsies will be. And so in these situations, barring some other need, whether it's, some other confusing factor, or a clinical trial or something else, these patients do not actually require biopsies because the imaging is so good at identifying what an HCC is. So then once we decide that this tumor is an HCC, the next thing we have to decide for ourselves is what stage is this patient. So this is where the next unique thing about HCC comes in, which is that they're not staged in the same way that other cancers are. So if you think about lung cancer, for example, people often will say, what stage do I have? Do I have stage 1, right? A localized cancer that hasn't spread anywhere? Do I have stage 2, stage 3? And in these stages, it usually means that the tumor has spread more aggressively, either to other parts of the lung or other parts of the lymph nodes. Or do I have stage 4 cancer, which typically means in many cancers that it's spread outside the primary organ, is metastatic now, and in many cancers that sort of is the cutoff between curable and not curable disease. Not in all, but in many. What's different about HCC is that we're really dealing with two different processes. One process is the cancer, which behaves, again, similarly to what I just described, right? Is the cancer localized in the liver? Has the cancer gone to the lymph nodes? Has the cancer gone to the lungs or the bone, and now it's metastatic? That is important with HCC, but what's also important with HCC is the underlying liver function. As I mentioned in the beginning, most of these patients are going to have underlying liver disease, cirrhosis of some sort, right? So hepatitis, alcohol use, fatty liver disease, something that is going to compromise their liver function. So in terms of the probability that these patients are going to survive, right? So if we look at their survival, it gets worse, not just based on how big the tumor is and what the tumor is involving. So up here we have a small tumor. Over here we have bigger tumors that have gone into the portal vein, many tumors here. So as we go in this direction from single small tumors to multiple big tumors, we make survival go down, so patients do worse. But also, if you notice what goes into the staging here, and this is a staging called the BCLC, it's kind of widely accepted staging method. We also are looking at their liver function and their performance status, because even if the tumors are relatively small, as their liver function gets worse, or as their performance status gets worse, their stage actually gets worse. And that's because these things are also going to contribute to these patients' survival. So if you have a really small tumor but really bad underlying liver disease, you're not going to do as well as somebody who might have a medium-sized tumor and perfect liver disease and perfect liver function. So we have to take both of these things into account. Now, what's important to know about this, because it's a very busy slide, is just that this slide keeps getting bigger down here. And these are the treatment options that we have. So this slide tells us how we stage people. Then it gives us treatment options that we have. And then it gives us an estimate of survival for those things. And then what we're going to do following those initial treatments. So these are always expanding, and we have many, many treatments available for these patients right now. But we're going to be focusing in on some of these here. So here's ablation. Here's TACE. Here is TACE and radioembolization again. So again, lots of things we're going to be talking about fit into this algorithm here. So this is just another thing that's important for everyone to be aware of and know. So there's something called the child score. This is, if you look back on the slide I had before, so this preserved liver function, this is relating to the child score here. There's some other ways of scoring these patients, something called a MELD score, an ALBI score. What's important to know are that these are attempts to estimate how bad a patient's liver disease is. Again, not related to their tumor, but how bad their liver disease is. And what's important for us, and this is, something that I don't know if it's always obvious to all of the nursing staff why we care about these things. But when we check the patient's labs and we want to know on the day of treatment, for example, what has their bilirubin been like? That's because as the bilirubin goes up, that's an indicator of worsening liver disease, which is why you can see here a patient who has a bilirubin of 3, that's going to give them several points, and so if you get 3 points, you only need a couple more till you're already a child's B. And you have a couple more problems, then you're a child C. And what these tell you is, so as you add up these points for all the problems patients have, then their survival starts to go down. And again, this has nothing to do with cancer. This is just their underlying liver disease. So we have to be very careful when we're treating these patients for their cancer that we're aware of what their underlying liver disease, which is why we care very much about these factors here. Has the patient have an elevated bilirubin? How low is their albumin? How high is their INR? Do they have ascites? And do they have encephalopathy? Any questions so far on just that kind of stuff? I'll just pause for a second. I think I can see everybody's hands here, so if you do, you can put up your hand. We can pause there too. So now we're going to jump a little bit into the treatment again, and we're going to focus initially on arterial therapy. So I promised a diagram, and this was the diagram I promised to show. So again, if we think back to the picture we showed in the beginning about the CT, that showed that the tumors were arterially enhancing. So during the arterial phase, they got very bright, and then during the venous phase, they got dark. That's because of this phenomenon that we're looking at here. So this is a diagram showing the arteries in red. This is the aorta. This is the hepatic artery. And so when we're doing arterial therapy, so you see that the artery is going to get bright again first as we inject the dye in, right, in the CT scan. And most of the tumors are going to be supplied by the arteries. Okay? So that means these tumors are going to get bright. But what you can see from this diagram is that the vein, which is the second source of blood that goes into the liver, doesn't really contribute very much to the blood supply to the tumors. It actually contributes most of the blood supply to the liver, the functioning liver, which is why we see that distinction that I showed you in the beginning on the CT scan. But what this actually helps us with is also helps us with treatment, because now we can take advantage of this kind of fact that if we deliver medication into the artery, that medication is going to concentrate in the tumors and again preferentially avoid going into the liver. So we generally have this rule, it's referred to sometimes as the 80-20 rule, which is that when we're talking about tumors, about 80% or more of their blood supply is going to come from the artery, and 20 or less percent is going to come from their blood supply from the portal vein. Then we flip that when we're talking about normal liver parenchyma. So in normal liver parenchyma, uninvolved by cancer, about 80 to 90% of that is going to come from the portal vein, and less than 10 to 20% of that is going to come from the artery. So again, this allows us not only to diagnose these tumors, but also to take advantage by delivering the medications directly into the artery. But when we're doing this and when we're treating any arterial therapy, we have to be careful of a bunch of different things. And these are topics that you guys, again, will see as you work with these patients in the angio suite. We're always thinking and talking about them, but this is the reason why we're doing it. So for example, the arteries are not just supplied directly into the liver, but they often will have something called extrahepatic supply. So here's an example of, a diagram of what we would say is the GDA, right? That's just one of the arteries that typically will come off the liver artery or the hepatic artery here. And you can imagine that if we're treating a patient like this, if we're injecting from right here, sure, we may get a lot going up into the liver, but we may get some that goes down into the GDA artery, the gastroduodenal artery, and that goes down to the stomach, the pancreas, and the duodenum. We wouldn't necessarily want to be delivering our medication down into there. There's no cancer there. That can only cause side effects and problems. So one thing we're always looking for, and especially when we're doing these Y90 procedures, is looking for any of these blood vessels that are leaving the liver. The other thing we always have to be aware of is where the blood's going to go after it goes from the liver, right? So the blood still has to get out of the liver somehow, whether it's coming in through the artery or the vein. That blood is then going to go into the hepatic vein and leave and go out back to the heart. This is what we call a lung shunt. So anything that I inject into the liver, eventually, if it's small enough, is going to travel through the liver and out to the lungs. Things that are big are hopefully going to get trapped in the liver or in the tumors themselves. But we always have to be aware of anything that we're injecting into the liver is going to go out, and at some point it's going to go to the rest of the body to some degree. And we'll get into this a little bit more in a second. The next thing we have to think about always is the hepatic reserve. So again, 80-20, 90-10, 95-5, whatever the number is in an individual patient is less important than understanding that some of these blood vessels, some of these arteries are not going out to tumor. So whatever I'm injecting into the liver, some of that is going to go into the regular normal liver parenchyma. That's why we have to be very careful, again, of the patient's underlying liver disease. So a patient with a bilirubin of, let's say, 2.5. who I'm going to be treating from right here. Well, if 20% of that ends up in the normal healthy liver, that might be really, really dangerous, right? Because we're going to be hurting a lot of the liver if that goes there. Now, maybe a patient with a bilirubin of 3, if I'm treating right out here where my arrow is, I may be getting entirely tumor here. So that might be a case where I'm less concerned about it. So these are the factors that we're always thinking about when we're trying to decide about how much hepatic reserve a patient has. So what does this all play into? And this is, I think, an important point for nursing to understand what we're doing. So again, what is all of this predicated on? How much liver reserve patients have. So if patients have very elevated bilirubin, that might mean they might not be able to tolerate very many of these treatments. Again, if patient has renal failure, everything I just described is based upon my ability. These are relative contraindications, right? So not absolute, but things we have to be thinking about. Well, I can't necessarily do my angiogram if I can't give them contrast dye, so that's one thing that we have to be thinking about. ECOG status, this is performance status. So again, what I said in the beginning, remember the staging of patients, what treatments are available to them really depends on how sick they are otherwise. So if patients are very, very sick, that may not be a good candidate we want to treat. And again, an excessive lung shunt. So if I'm injecting into the liver, because I'm trying to concentrate the drug in the liver, but all of that's going right through the liver and out into the lungs, that may not be a very effective treatment either. So these are all things that we are thinking about as we decide on a patient for arterial therapy. So what's the data? How do we come to learn that these arterial therapies like chemoembolization, radioembolization, that they work? Well, it started back in the 90s with these 2 papers. These were considered landmark papers at their time. They basically were, relatively small but randomized studies where patients got either traditional chemoembolization, and the details here are not so important, but traditional chemoembolization or standard of care, which at that time was basically, nothing, right? So it was basically just symptomatic care because there really wasn't anything else for them. And patients got conventional chemoembolization. I'll describe what that means in a second. But basically they got chemotherapy delivered into the artery, the way I just described, through a little catheter. And then the artery was blocked off with gel foam, essentially. So you blocked off the blood flow. You delivered the chemotherapy and then you blocked off the blood flow. And they got that kind of in a routine fashion over and over again every couple of months. And what they saw in both of these papers, and these were different patient populations, they saw that patients that got chemoembolization or TACE had much better survivals at every step along a 3-year process. So in the first year, they did better than the controls. Again, 57 to 32 in this study, 82 to 63 in this study. And then even out at 3 years, the patients who had TACE survived much longer than the patients who didn't. Interesting that one of these studies also looked at doing a chemoembolization minus the chemo, what we call today a bland embolization. I have here, this was not statistically significant because it wasn't at the time and the study wasn't designed to look at that, but we're going to come back to that in a second. So essentially these papers, when they came out in the late 90s, basically opened the door for everyone saying, all right, so when we're dealing with HCC, chemoembolization saves lives, people will live longer, at least to 3 years out. And that became the standard of care treatment for patients. But what were some of the problems that we ran into? And these are things that we're still aware of and we see to varying degrees, right? So the toxicities. So what happens? So again, the chemo at this time was a liquid form of chemo. Essentially, we take Lipiodol, which some of you are familiar with. It's an oil-based contrast. We use it for a bunch of different things. It's really made from poppy seeds, so it's really a poppy seed oil. And when you put it under an X-ray, it's dense enough that it looks dark. So you would mix together a chemotherapy with this liquid contrast dye that was pretty thick. It was kind of like a pasty consistency. So when you injected it, it would kind of stick inside the blood vessels. It wasn't quite thin enough to just wash out like chemo was. So again, if I'm giving just liquid chemo into the artery, that's going to flow right through, just like you would give any saline or anything else. That's going to go right through the liver and out into the body. And that's no different or better than just giving chemotherapy through a port. So this contrast dye was meant to get it to stick inside the tumors and stick inside the liver. But because it's not a perfect situation, some of it would leak out from the liver and go to the rest of the body. So what you saw in these patients was, yes, issues related to treatment of the liver, like liver failure and abscesses. Again, these were rare, but you saw them. But what you also saw in this population was a lot of systemic uptake of the chemo. So you saw hair loss, you saw their bone marrow being suppressed, their skin changes, mucositis, basically like you were giving the patient systemic chemo through a port. right, which was not what we were trying to do. We were trying to take advantage of that 80% rule and get the chemo to stick in the liver tumors. We also saw something called post-embolization syndrome, and we're going to come back to this over and over again, because this is still something that we deal with today, which is livers don't like having their blood flow cut off to them. So if you cut off the blood flow to any organ, but the liver included, patients act as if they are kind of inflamed and infected. So you can have pain, you can have nausea, and you can have a fever. And this is something that I think comes up quite a bit, especially if you're doing the triage calls or the calling patients day or two after a procedure, that this post-embolization thing comes up a lot. So you saw this very, very commonly. Greater than 80% of patients with traditional chemoembolization used to get post-embolization syndrome. So after that, we decided to start looking into alternatives, and one of those alternatives is something called drug-eluting bead TACE, or DEB TACE, or what you see us do much more commonly at City of Hope nowadays, which is the particle TACE. So this is where, instead of mixing the chemotherapy, the doxorubicin in the case that we see most commonly today, with that Lipiodol contrast material, we would now attach the chemotherapy directly onto these beads, and they're kind of linked by actually an electrical charge, like an ionic charge, between the particle and the chemotherapy. So they sit in pharmacy overnight, and the chemotherapy inherently binds to each one of those beads. So then when I inject the bead, that chemotherapy really can't break off, and when it does break off, it breaks off very slowly over time. So it's meant to not kind of leach out into the systemic circulation very quickly, instead kind of stay locally right where the beads are. Because the beads are calibrated, so when we say like 100 to 300, you'll hear us ask for that all the time in the angio suite, or 300 to 500, we're talking about the micron size of the beads, the diameter of those beads. So if a blood vessel is 50 microns, let's say, and I'm delivering in a 100 micron bead, that bead's going to get stuck in the blood vessel. There's nowhere for it to go. So it's going to get stuck there. Then the chemo is just going to release locally from where that bead is stuck. So we should have two things happen then. We should have the drug concentration in the tumor should go up because it's not washing out of the tumor like a liquid would. It's sitting right where the bead was. And the other thing we should see is we should have better tumor killing because the chemo is staying where it's supposed to go instead of washing out. And the other thing we should see is that we should see lower side effects because the chemo is not going everywhere in their body anymore. So that's the theory. The problem is the theory is not always true. So we eventually studied this, and this trial is already back now, almost 15 years old, but we compared both things. We compared the chemoembolization with Lipiodol, so traditional chemoembolization, versus drug-eluting bead chemoembolization. And what we saw in this randomized trial of 212 patients, that there was no difference, that patients didn't do any better, the cancer didn't respond better, whichever one we were using. So that idea of concentrating the chemo in the tumor didn't really seem to play out as much. What we did see, though, is we saw a lot less side effects. So the tumors didn't die better because the chemo was sitting there, but because the chemo wasn't being absorbed throughout the body, we weren't seeing hair loss and mucositis and skin changes and all these other problems because the chemo really was still sitting in the liver. Okay, so that maybe is a good enough reason to do it anyway, right? So even if we're not killing the tumors better, if we're getting fewer side effects, fine, then we should maybe do chemoembolization that way too. And that I think is a large reason why at least we at City of Hope have kind of decided to move away from traditional chemoembolization a lot. That's not true everywhere in the country. It's certainly not true everywhere in the world. But it's been our preference to go with the drug-eluting bead for that reason primarily. But it also raises the second question. Well, if the chemo sitting in the tumor is not killing the tumor better, then people start asking themselves, well, what is the chemo really doing? We know the chemo's sitting there because we know it's not going everywhere else in the body, so where else could it be going? So it's sitting in the tumor tissue, but the cancers aren't dying any faster. So it made people start asking themselves, does this mean that actually the chemo is not really doing much? It's really the bead itself that's blocking off the blood to the tumor that is causing the cancer to die. So we decided to look at that too. So this was a study that was looking at 101 patients where they gave patients either the bead plus the chemo or just the bead alone. and tried to see, do the cancers die off any differently? And what they saw in this study, now this is not the be-all and end-all of studies, but it did at least, was one study that demonstrated that at least in this protocol, they were not able to see any difference in the response of the tumors, whether the cancers had whether the drug had chemo in it or not. So basically what this study argued was that if you block off the blood to the tumor, you will kill off the cancers just as well as if you block the blood off to the tumor and stick chemotherapy on the inside. Okay. So this is what we would call bland embolization, right? So this is embolizing the tumor without giving any chemo. Now, we can spend time at the end talking about how we would choose between any of these different things, but needless to say, I think there are still niches for each of these things, and a lot of our decision when we're deciding which treatment to use on a specific patient comes down to those kind of nuances. But generally speaking, it would be very hard to argue with any person who is choosing any single one of these treatments for any specific patient with HCC. Okay, any questions on that stuff so far? If I don't see hands pop up, then I will just keep going. Okay, so what is Y90? Sorry, give me 1 second. So Y90 is the same idea. So think about everything I just said. Really, all of it's the same, right? We're still concentrating whatever we're giving into the tumors by going through the hepatic artery. All the same rules still apply, but the difference is now the beads are way, way smaller. So remember we said before, like a traditional chemoembolization might be 100 to 300 microns, something along that line. We're talking, many orders of magnitude smaller with these beads. These beads are so small that they don't really cause any visible blockage of the blood flow to the liver or the tumor. So if you do an angiogram and you see the blood flowing out to the liver, and then you deliver in Y90, right after you do that, you do another angiogram, the blood flow looks like it's exactly the same to the liver. There's no stopping of the blood supply in there because the beads are so small. Not so small that they don't get trapped in the tumor, hopefully, but small enough that they don't block off any of the bigger blood supply. So the beads get much deeper into the tumor itself. Then, instead of blocking off the blood flow and killing the cancer that way, instead of delivering chemotherapy that way, the radiation goes about 2 to 10 millimeters away from each one of these beads. So if you have a bunch of beads clustered together in the tumor, each one of them can supply radiation about 2 to 10 millimeters away from those beads. You can get that radiation concentrated very directly inside the tumor. That is what a Y90 is. It's trying to concentrate radiation directly inside the tumor. Make sense? This dose of radiation is orders of magnitude higher than radiation that would be given if it's given on the outside of the body. Okay, so in addition, because we're not delivering radiation like an X-ray beam from the outside here, like you would with traditional radiation, you're not going through, that radiation beam is not penetrating through normal structures. So we don't have to worry about that radiation, injuring the stomach, injuring anything else, because it's concentrated just inside the liver. And again, can only go a couple of millimeters outside of that. So you're not going to get doses of radiation to organs outside the liver to any degree. Oops, too fast. So how well does radioembolization work? It works actually really, really well, right? So some new data has been slowly accumulating over the last 5 to 7 years or so. This is just one example of that. This was called the Legacy study. This was a non-randomized single-arm study where patients who had tumors less than 8 centimeters, so really big tumors, again, this is child's Pew A, BCLC, A to C. So again, their liver function was really good. Their tumors were big, so they were higher stage for that reason. Their portal veins were all open. So these were fairly decent for a liver cancer patient, livers. And what we saw is that 89% of those patients had a response in their tumors. So, the vast majority of patients, their tumors shrink when they get Y90. In addition, we saw that their tumors stayed shrunk 62% of the time beyond 6 months. And 86% of those patients were alive at 3 years. Now, again, this is not a direct comparison to those first studies I showed you on traditional chemoembolization, where like at 3 years there was like a 20% survival after TACE, and patients were getting treatments every 2 months. But so this is a healthier population. It's a different, it's not a head-to-head comparison. But needless to say, even if we take a step back and we take that into account, these are much better results than we saw with those traditional chemoembolization patients. What else have we learned over time? We've also learned that as we increase the dose of radiation to the tumor, patients do better. So this was just a more recent study that was looking at the amount of radiation one should give to these tumors. And again, Y90 has been an evolving science over time. But what we saw was that in the early days, we used to think that this marker, 120 gray to the liver, was what we would be aiming for. And what they showed in this study is actually that if you go much higher than that, you get much better responses. So again, what the point of this is to tell you is that we're still learning how best to treat these patients with Y90, but what we are realizing is that the higher the radiation, the more dose we give to these patients, the better they do, and they can do much, much better than our traditional treatments had been available for. So one more concept that is I think everyone should kind of be aware of, because this is where the field is really going now. As I mentioned, when we saw that crazy algorithm slide that had all the arrows pointing in all the different directions about you do this, then you do that. Over the past several years, a lot of systemic therapies. I'm not going to call them chemo because most of them are not chemo. Here's an example of one, which is durvalumab, which is an immunotherapy, and bevacizumab, which is a targeted agent that attacks blood vessels. This is one of the treatments that's now available as a systemic therapy. So, systemic meaning that they get it through a port or they get it through an IV and it goes everywhere in their body treatment. Those treatments combined with the arterial therapy treatments are starting to show benefit. So this is the most recent study that looked at this, and this was a very large study, over 600 patients at multiple centers around the world. And they divided patients into 3 groups. Patients that got this regimen plus a chemoembolization, patients that got just the immunotherapy plus a chemoembolization, and patients that got just a chemoembolization. And essentially what they saw in this study is that patients that got everything did better. And this is really where the field is going now. It's now that we understand that we have a lot of these therapies, none are perfect, can they be combined together to get more optimal benefits? So when I say, for example, the nurses here will be aware, when we have a patient that we're treating on trial for Y90, what we're talking about is doing a regimen similar to this. It's a different immunotherapy that they're getting, but they're getting 2 immunotherapy medications in combination with our Y90. Same concept as this, are we going to kill off the cancer with the Y90? We're going to do a good job of it. Are we going to leave some of the cancer behind? In many situations, yes. If we add on immunotherapy, can we get those patients to survive even longer? So that is kind of what we're doing right now when we have those trial patients that we're seeing for Y90. Okay, so how do we choose between all those things that I just said? Well, the bottom line is with that exception of that one small trial that was looking at chemoembolization, conventional versus drug-eluting bead, we don't really have any studies that compare these things head-to-head. There's no TACE versus Y90 randomized trials. There's no BLAND versus Y90 randomized trials. So we're really going based on kind of all the other nuances. So what does that mean? Well, some things should be obvious, right? So again, if there is going to be a patient where we can treat really, really selectively and have very little effect on the surrounding liver, well, then we may be able to go with treatments that are more aggressive in that fashion. So maybe we'll go with a Y90 because we'll be able to treat it very selectively in that case. On the other hand, if we're going to have a big lung shunt, because those beads are so small and are going to pass through the liver and go to the lungs, Y90 might not be a good option in those cases. Again, the post-embolization syndrome that we talked about, that fever, that pain, that nausea, that is mostly related to blocking off the blood flow to the tumor. So if side effects like post-embolization syndrome are a major issue, then Y90 is a lot better for those patients, right? Because those patients, we're not blocking off the blood flow, so the Y90 side effects tend to be much, much less. So we may choose it for that reason. So there's a lot of nuances that will go on to those things, how we decide. But this is one of the reasons why we can discharge patients with Y90 same day, and sometimes patients after chemoembolization have to stay overnight, and that's because that post-embolization syndrome is a lot lower with Y90. They get more fatigue, but they can typically go home from the hospital the same day. So again, you guys are all pretty much aware of these things, but now we maybe understand a little bit better why we do them. So again, when it's talking about Y90, about 99% of patients could be discharged home the same day. This has actually been shown with chemoembolization also to be the case if you prep them enough, right? So what is prep them enough? Make the patients understand what it is that they are going to be typically expecting afterwards. Give them enough pain, nausea, all those kinds of medications that they typically can be discharged the same day. You know, we have not pushed for same-day discharge for chemoembolization at City of Hope recently, and that's because we haven't really found the need to do that, but there are places where that protocol is more robust and patients go home regardless of what they get the same day. Regardless, we're protecting against all of those things we're expecting to see. Remember from the beginning, one of the risks is infection. That's why the patients get prophylactic antibiotics. Pain control and nausea, because we're expecting to see that after a post-embolization syndrome situation. Steroid taper we do for Y90, typically, again, because of the fatigue and the risk of radiation injury to the liver. That's why the patients get the steroid. And a PPI, because there is some gastric reflux that can happen, and God forbid any particles make it into their stomach. PPIs are thought to decrease the risk of any problem. So again, those extrahepatic collaterals we talked about, if any of our particles go out and end up in the stomach, that can cause ulcers. So we put patients on PPIs. So that's the reasons why we discharge patients on those things. We're all aware of the groin or radial access care things. Again, this is, regardless of what you're doing, this is the same for any patient. We're just protecting them against bleeding from the access site. And important to know that most of these side effects are going to resolve within about 7 to 10 days. So what that means, and this is kind of the most important thing for our nursing staff to know when they're doing these post-op calls, if you're having a low-grade fever, if you're having some pain, if you're having some nausea 1, 2, 3, 4 days after the procedure, that can all be entirely normal. Okay, now it doesn't mean it's always normal, but it can be. That's not unexpected. Now, if a patient's calling back 14 days after a procedure and they said, I was feeling fine and then I woke up this morning with a fever, that's much more concerning because that's not likely the course of post-embolization syndrome. Then you have to worry, is there something else going on? Do they have an infection? Is there some complication or something along those lines? So the time course is very, very important. And understanding, a typical fever for post-embolization is like 100 to 101. 104 is atypical. So if 2 days later they have 104 fever, again, that's atypical. But again, we do expect to see some of these things. This is just more on what I just said already. So again, common side effects we're going to see, post-embolization syndrome. Feels like the flu. You're tired, you're nauseated, you have some pain, you have a low-grade fever. That is what post-embolization syndrome feels like. First 1 to 3 days afterwards, and then starting to tail off. Very normal, expected, usually nothing to get concerned about. Complications are when there's a problem. So severe fatigue, abnormal liver enzymes, things like that are going in the wrong direction can be a sign of liver toxicity. If any particles, whether Y90 or chemo, got out of the liver, leaked out through one of those blood vessels I mentioned and ended up in the stomach or the duodenum, patients get pain and ulcers, so really severe pain in the stomach area, that's more concerning. And then again, we talked about that lung shunt, so if particles make it up to their lungs, patients could be short of breath. So a patient calls or has, within 48 hours has, difficulty breathing, again, not a normal thing, then we start worrying about complications of those treatments. Okay, something that also comes up our nurses ask about a lot and that patients are asking the nurses about is this radiation issue. So patients get Y90, how long are they radioactive for? So a couple of things to be aware of. Again, if you remember the Y90, it's a little particle, it's stuck inside a tumor, that tumor is in the liver, that liver is in the body, right? The radiation exposure, again, from a typical particle is 2 to 10 millimeters. So as long as there is 2 to 10 millimeters of distance between the particle and the outside world, very, very little radiation is making it anywhere outside of the body, right? So this, if these patients were severely radioactive, there would be radiation going throughout their bodies, right? But it doesn't really travel very far. That said, a little bit does leak out, so that's why these patients are measured before they go home to make sure that their radiation levels are low. The half-life, which means the amount of time it takes for the dose of radiation to be cut in half, is 64 hours for Y90. So that means after 64 hours, if I put in 1 gray, I have half a gray left. After the next 64 hours, I'll have a quarter of a gray, and then an eighth, and keep going down. So really, after it's that first when the radiation is at its highest is really in that first 2 to 3 days before it starts going down quite a bit after that. So that's when we tell patients, if possible, try to sleep alone. And again, what I tell them is essentially, it's one thing to be walking by somebody who has a minimal amount of radiation in their body. That's going to have really no effect on you. But if you press up next to somebody and lie there for 8 hours, in theory, that little bit of radiation can cause some effect to the outside world. So again, if possible, we sleep alone for 3 days. There is some leakage that goes into the urine, obviously not enough to cause any damage because patients aren't coming back with problems with radiation to their bladders. But because again, we're trying to minimize radiation exposure to the world, they have to be very careful, flush the toilet twice, make sure there's no, urine leaking out around the bathroom. And again, always be extra careful when we're talking about children and pregnant women because they have radiation exposure to deal with for their entire lives, and we want to keep the radiation exposure to the most vulnerable people to an absolute minimum. So usually what I tell people is basically COVID rules around kids and women. Being in the same room with them is no problem, but keep a 6-foot distance kind of thing because there is zero radiation measurable at that distance. So again, probably not a great time to have a 1-year-old sit on your lap for 5 hours kind of thing. Okay, we're going to move on to ablation. I still don't see any hands up, so we're going to just keep going right now. So why do we do ablation, right? So we just talked a lot about the arterial therapies. So again, we're not just talking about HCC here, but we're going to use it as kind of a jumping off point. When you have lots of tumors or very big tumors, the arterial therapies can be very effective. They shrink the tumors, they keep them shrunk, they do a good job of that. But with some exception with Y90, the majority of these tumors are not completely cured by the arterial treatments I've been talking about, right? So they shrink them down, they kill them off, but eventually, given enough time, they start to grow back again. Ablation is very different. If you have a tumor that is ablatable, so a relatively small size, relatively few of them, and you burn that tumor completely, that tumor is gone. There are no cancer cells that survive that temperature. Cancer cells can survive chemo. Cancer cells can survive radiation. No cancer cells can survive, over 100 degrees centigrade of treatment for several minutes, right? They just burn. Everything is completely dead. So if you're going for a local cure, then ablation is typically a much more effective strategy. The problem with it, however, is that when tumors get big or when there's too many of them, you can't ablate them because you can only burn a certain amount. Once you're burning bigger than that, you're going to either run into problems or you're not going to burn at all and the tumor's going to grow back anyway. So when we're generally deciding between ablation or an arterial therapy, we're generally picking between, are we trying to control the disease because we don't think we can cure the patient, and we're trying to give them as much longevity, quality of life as possible, or is this somebody that we actually think we might be able to cure the patient or cure that specific cancer? It may be that they come back with another cancer somewhere else in the future, but this particular spot we're treating, we want it to be gone completely. Then we would choose something like ablation. Now, you could ask the opposite question. If we're going to try to get rid of a cancer completely, why would we not just go ahead and cut that cancer out? I'm going to go into that. It should be obvious already why we're not going to put a patient through a major operation if we don't have to, but we're going to get into that now in a second. Radio frequency ablation, basically we don't have to talk about it because for the most part, in things like liver tumors, it's pretty much something of the past. We still do radio frequency when we're treating bone, I would say is the most common area. As some of you know, we're starting to do this in the thyroid as well. It has some benefits in terms of those specific situations, in terms of its controllability and predictability. The problem with it is it's slow to burn and it doesn't burn very big. So when you're treating cancers in the liver, those are two things that hurt you. So you want to be able to burn in the liver big and fast. That will give you better cure rates. That's why we moved to microwave ablation. Microwave ablation is just like the microwave in your house, except instead of it being a box, it's a little needle, we call it an antenna. That antenna delivers electromagnetic waves that get broadcast. Think of it like a cell tower. It's broadcasting, or a television tower, where it broadcasts out that energy within, depending on each device, within a couple of centimeters. Everything within that area where it's being broadcast to, the water molecules start spinning because of the way the electromagnetic waves work. As they spin, they kind of get agitated, and that causes those water molecules to get extremely hot. That's how it works in a microwave. That's how it works in your body when you're doing this. And that allows us to, if you see here, where as it takes a little bit of a while for radio frequency to get hot, and then it maxes out around 100. With microwave, you get hot almost instantaneously, and then you continue to keep getting hotter and hotter and hotter. This allows us to make bigger, more effective ablations than radio frequency ever could. How well does ablation work? Well, it works really well. This is an older study. This is back from now nearly 20 years ago, where they looked at older devices where they were treating with this was a mix of radio frequency and the old version of microwave. And essentially what they saw when they were looking at HCC is if you were dealing with small tumors, you had the exact same outcomes as you did whether it was with ablation or an operative resection. More recently, this is a trial that was just done this year. This is a randomized trial, very large, in the Netherlands, 341 patients. This was with colon cancer. So again, same concept though, where patients were randomized either to get ablation or resection of their tumors. And what they saw here is that survival between the two groups was identical, whether you had surgery or you had ablation. But what was a difference was the side effects and everything that went along with it. So adverse events, this is complications, length of stay in the hospital, local control, meaning the tumor growing back right in the same spot, and mortality from the procedure itself all favored ablation. So that meant if you were going to live the same amount of time regardless of what you had, but you'd be less likely to have an adverse event, stay in the hospital shorter amount of time, have a better chance of the tumor not growing back, and have less of a chance of dying during your surgery if you had an ablation over surgery. So this is starting to change the method or change the thinking a lot around this. So I think this trial, along with others that are coming out, we're going to start to see our ablation volumes increase even more, because again, it's showing us what we pretty much already knew, is that putting a little needle into a tumor and burning it is a lot safer and better for patients than cutting them open and cutting out big pieces of their liver. Ablation suffers from a similar kind of side effect profile as the other treatments that we talked about. We don't call it post-embolization syndrome because they're not getting embolized, but we call it post-ablation syndrome. Again, this is inflammation within the liver, right? So the reason I tell patients that you get this is your body does not know if, when all those white blood cells and all that inflammation go in and start chewing up the tumor that we just burnt or embolized, your body doesn't know whether it's going in to chew it up because it's dead and sterile or because it's dying and infected. So that inflammatory response that patients get that causes these flu-like feelings, this fever, fatigue, nausea, looks very much like an infection, which is why they get these kind of symptoms afterwards. The key is for us is always being able to differentiate, because infection is a risk of these procedures as well. So again, day or two afterwards, patients feeling fatigued, discomfort, low-grade fevers, this can all be very normal after an ablation as well. And it's really our job to figure out, is this the normal response or is this the, something else is going on situation? We treat it much the same way as we treat everything else. So again, we send patients home with antibiotics to prevent infections, anti-inflammatory pain control medications, same as we talked about before, anti-nausea medicines, same. Again, we're expecting these procedures, these side effects afterwards. So we treat all patients the same. What are some special things that sometimes patients will mention to you on the phone when you're doing post-op visits? Well, one thing to know is that there are situations where patients are at higher risk of infections. These are patients who've had procedures of their biliary tracts in the past. So sometimes these patients are actually going to be on antibiotics for several weeks to a month after the procedure. Sometimes that can be an issue that comes up that we have to talk to them about. The other issue is with ablation is that, sometimes we're treating tumors that are very close to the surface of the liver. The surface of the liver has all the nerve fibers in it. So pain after this can be worse. It can be localized pain after an ablation. That's sometimes the reason why we have to keep people in the hospital overnight, is because of that. Also, we have to be aware of referred pain. The diaphragm sits right on top of the liver. The diaphragm sends its nerve fibers, they get kind of crossed in the body. They refer pain to the right shoulder. So a patient who had a dome ablation liver an ablation of a liver dome tumor 2 days ago, and you're doing a post-op visit, and they're like, yeah, my stomach kind of hurts, and I've been having all the normal kind of things that you would expect, but you know what's really weird is my right shoulder just really hurts. Or I've been having some hiccups. Those can all be signs of either inflammation or injury or something to the diaphragm, which causes that referred pain. Most of the time, we don't treat it any differently. We just let the pain resolve on its own with the same things we would do for everything else, and rarely do patients need anything more than that. Again, much like with an embolization, 7 to 10 days, you expect all of these side effects to resolve. That is all I had for us for today. I am happy to answer any questions you guys have, either directly or indirectly, on the things that we covered. Oh, I see Anna has a question, a hand up. So go ahead, Anna.